The following podcast is part of a certified educational activity. Access the entire activity and complete the post-test at peerview.com/KFY860. Downloadable slides and practice aids are also available.
Hello, my name is Heather MacArthur, and I'm a medical oncologist at Cedars-Sinai Medical Center in Los Angeles, California. And today we're going to be talking about harnessing the immune system in the treatment of triple-negative breast cancer and beyond. Where are we now, and where are we going next? So as we're all aware, checkpoint blockade is incredibly promising as an anti-cancer treatment strategy because it confers durable responses, as you can see in the spider plots here, these horizontal lines indicating that when responses occur, they can be very long-lasting. However, unfortunately, only the minority benefit. As evidenced here, first-line treatment, approximately 25% of patients benefit to immune therapy alone, and even fewer in the second line and beyond. So how do we make these strategies relevant to the majority population? And if we look at the cancer immunity cycle, we might get a hint as to what strategies might be necessary. So there's a whole long list of activities that need to happen before immune therapy becomes relevant. In fact, PD-1 or PD-L1 directed therapy actually comes into play in really the last steps of the cancer immunity cycle. So it's probable that if we're going to make these strategies relevant for the majority of patients, that it will require combination strategies that address some of the other steps of the cancer immunity cycle. We know that chemotherapy can sensitize tumors to checkpoint blockade. Although it can be immunosuppressive, the right agents at the right doses at the right time can induce T-cell responses, and that's been observed with many of the cytotoxic agents that we use routinely for the treatment of breast cancer. And so a number of phase 1 and phase 2 studies looking at combination checkpoint blockade with immune therapy ultimately led to the Impassion 130 study. This is the first randomized study reported in patients with previously untreated metastatic or inoperable advanced triple-negative breast cancer. This was a global study where patients were randomized 1-to-1 to receive nab-paclitaxel with either atezolizumab or placebo. There were a number of stratifications: prior taxane use, the presence or absence or liver metastasis, and PD-L1 status. It's worth looking at a few of the baseline characteristics of the patients who participated in this study. First of all, it's notable that approximately 40% of patients participating in this study had tumors that were deemed positive for PD-L1 by the Ventana SP142 assay. It's also worth noting that approximately 60% of patients received neoadjuvant or adjuvant chemotherapy, indicating that approximately 40% of patients in this study had de novo metastatic disease, a proportion that might be a little bit higher than what we might see in clinical practice. So these results were first presented at ESMO 2018, and the primary progression-free survival analysis is demonstrated here. There was a slight improvement in progression-free survival in the intention to treat population, 5.5 versus 7.2 months, and a slightly magnified improvement in progression-free survival for the PD-L1 positive subset of 5 months versus 7.5 months. In the first interim overall survival analysis, there was not a significant improvement in the intention to treat population, 17.6 versus 21.3 months, which was not statistically significant. And so an informal analysis of the PD-L1 positive subset of patients was undertaken with an improvement in overall survival of 9.5 months, from 15.5 months in the control arm to 25 months in the arm who received atezolizumab. So when we think about the context of metastatic triple-negative breast cancer, the typical life expectancy for patients who have newly diagnosed metastatic disease is typically 18 to 24 months. So to have an improvement of 9.5 months in overall survival in this poor prognosis population was truly remarkable. This overall survival analysis was since updated at ASCO 2019 with a maintained improvement in overall survival in the PD-L1 positive subset of 18 versus 25 months. So this data ultimately led to the FDA approval of atezolizumab in combination with nab-paclitaxel. Specifically on March 8, 2019, the FDA approved the combination for patients with advanced or metastatic triple-negative breast cancer whose tumors express PD-L1 in immune cells of any intensity covering at least 1% of the tumor area as determined by an FDA-approved test. So this was the first FDA approval of immune therapy for the treatment of breast cancer and represented a landmark moment. There have been a number of other studies that have been since reported in the metastatic setting. This is the Keynote 355 study. It was recently reported at this past ASCO 2020 by Dr. Cortez. In this study, patients were randomized 2-to-1 to receive chemotherapy with pembrolizumab or placebo as first-line treatment. Notably, it was physician's choice chemotherapy, so the choices of chemotherapy included paclitaxel, nab-paclitaxel, or the combination of gemcitabine carboplatin. Patients were allowed to enroll if they had received curative intent treatment at least 6 months prior to first disease recurrence. So that's in discord with the Impassion 130 study where a 12-month disease-free interval was required. Patients were stratified by the chemotherapy received on study, PD-L1 tumor expression by a different assay, the Ventana assay, with a combined positive score determining positivity versus not, and prior treatment with the same class of chemotherapy in the neoadjuvant or adjuvant setting. In this study, there were two primary endpoints, progression-free survival and overall survival in patients with PD-L1 positive tumors, defined as a CPS combined positive score of greater than or equal to 10 and greater than or equal to 1, so two separate definitions for both progression-free survival and overall survival. And they also interrogated the progression-free survival and overall survival in the intention to treat population with a number of secondary endpoints as well. When we look at the baseline characteristics for this population, it's worth noting that 75% of patients were deemed PD-L1 positive by the combined positive score greater than or equal to 1. Again, in Impassion 130, approximately 40% of patients were positive by the Ventana SP142 assay. Also, it's worth noting that approximately half of the patients treated in this study had received their treatment at least 12 months prior to enrollment, with only approximately 30% of patients having de novo metastatic disease. Again, in contrast to Impassion 130, where approximately 40% had de novo metastatic disease. So here's the progression-free survival for the intention to treat population. There was an improvement in progression-free survival of 5.6 versus 7.5 months. And then honing in on the PD-L1 positive population specifically, an improvement in progression-free survival of 5.6 months versus 7.6 months for those defined by a combined positive score greater than or equal to 1, and a larger benefit observed in those who had a combined positive score of greater than or equal to 10, specifically 5.6 versus 9.7 months. Overall survival data are still pending. We also recently saw the results of the Keynote 119 study. This is a study where 600 women were randomized 1-to-1 to receive either pembrolizumab as monotherapy or physician's choice chemotherapy. And physicians had a choice of either capecitabine, eribulin, gemcitabine, or vinorelbine. There was a stratification by PD-L1 status, again using the combined positive score, and prior neoadjuvant adjuvant therapy versus de novo metastatic disease. And patients with metastatic disease were required to receive 1 or 2 prior lines of systemic therapy for their metastatic disease. The study did not meet its primary endpoint, so this is overall survival data by intention to treat population by the combined positive score greater than or equal to 1 or the score greater than or equal to 10, with no significant improvements identified in any of those populations. However, an exploratory analysis looking at a combined positive score greater than or equal to 20, there was an improvement in survival of about 2.5 months observed in that population, although again, these were exploratory analyses. Are there other notable recently reported immune therapy trials for early stage triple negative breast cancer specifically? And the I-SPY 2 study really gave us a sense of data that would come from a phase 3 study. So this was an adaptive trial design, so it's not designed to compare study arms head to head. It's designed to provide an estimated pathologic complete response rate to give a prediction of what strategies are most likely to be effective in a phase 3 study. So in the I-SPY 2 study, there was an arm where pembrolizumab was administered with paclitaxel prior to doxorubicin and cyclophosphamide neoadjuvant chemotherapy, with an estimated pathologic complete response rate of 60% for the pembrolizumab containing arm versus 20% for the chemotherapy control arm. So a threefold improvement in pathologic complete response with the addition of immune therapy to the paclitaxel. And this is the first phase 3 study that has been reported. This is the Keynote 522 study. This was a study looking at neoadjuvant chemotherapy with either placebo or pembrolizumab prior to surgery, and then either adjuvant placebo or pembrolizumab depending on the study arm assignment in patient with newly diagnosed triple negative breast cancer, stage 2 or stage 3. Patients with PD-L1 positive or PD-L1 negative tumors were allowed to enroll. The chemotherapy backbone in this case was comprised of weekly paclitaxel together with carboplatin, which could be administered either every 1 week or every 3 weeks, followed by either doxorubicin or epirubicin with cyclophosphamide every 3 weeks for 4 cycles. And here is the primary endpoint data for the intention to treat population. There was an improvement in the pathologic complete response rate of 14%, which is remarkable in this setting. And in discord from what we saw in the metastatic setting, the magnitude of the benefit was actually larger for the PD-L1 negative subset of patients rather than the PD-L1 positive, 18% versus 14%. Not statistically significant, but hypothesis generating and consistent with our beliefs that administration of immune therapy earlier on in the course of disease is most likely to be effective and to be effective for more patients. And there was an exciting event-free survival analysis that was presented. This is unstable data with only 15 months of median follow-up. However, it suggested that at 18 months there would be a 6% improvement in event-free survival, indicating real improvement in cure rates, and certainly further follow-up is highly anticipated. The neoadjuvant IMpassion031 study was also recently completed. This is a study looking at nab-paclitaxel followed by doxorubicin with cyclophosphamide and either placebo or atezolizumab before surgery in the neoadjuvant setting for stage 2 and 3 breast cancer. There was a press release approximately 2 weeks ago, specifically on June 17th, stating that the phase 3 IMpassion031 study met its primary endpoint by demonstrating a statistically significant and clinically meaningful improvement in pathologic complete response for the treatment of patients with early triple-negative breast cancer, regardless of PD-L1 expression. So similar to Keynote 522, meeting its primary endpoint of pathologic complete response, regardless of PD-L1 expression. So the details of those data are very highly anticipated. There have been a number of other studies in the neoadjuvant setting. Specifically, the NEO-TRIP study was a study randomizing 280 women with quote-unquote high-risk disease to receive carboplatin with nab-paclitaxel and plus or minus atezolizumab prior to surgery, and after surgery received an anthracycline-based regimen. And they observed no difference in pathologic complete response for the intention to treat population or for the PD-L1 positive or PD-L1 negative subset. So this data is discordant with the data seen in Keynote 522 and with the data promised from Impassion 031. But it's also worth noting that pathologic complete response was not the primary endpoint for this study, and so further follow-up of the primary endpoint, the event-free survival data, is anticipated. One other notable study has been presented in this space. This is the GeparNuevo study. This is a study where people received nab-paclitaxel followed by an anthracycline-based regimen with either placebo or durvalumab prior to surgery, and notably a proportion of patients in this study received a run-in prior to initiation of chemotherapy with durvalumab versus placebo alone. And here's the primary endpoint. There was no significant improvement in pathologic complete response, 44% versus 53% in the durvalumab arm, with a p-value of 0.28. However, in a hypothesis generating exploratory analysis, there was almost a 20% improvement in pathologic complete response for patients participating in the window study where they received durvalumab prior to initiating chemotherapy versus placebo prior to initiating chemotherapy, indicating that it's possible that the timing of administration of these immune therapies is potentially critically important. So there are still more questions potentially than answers, and there are a number of ongoing large studies that will aim to ask and answer some of these questions. The SWOG 1418 study is a study randomizing patients to pembrolizumab or observation if they have residual triple-negative breast cancer after completing neoadjuvant chemotherapy, and those results are anticipated sometime in the coming couple years. There's also the adjuvant study Impassion 030. This is a study where patients are randomized after upfront surgery to receive chemotherapy with or without atezolizumab, and that study is enrolling presently. What about new research directions? Are there opportunities to expand the role of immune therapy for triple-negative breast cancer? So certainly there have been a lot of efforts looking at other chemotherapy partners together with immune therapy, and this is a study conducted by Dr. David Page looking at either paclitaxel or capecitabine as first or second line palliative therapy together with pembrolizumab. And notably, he found that the overall response rate in the capecitabine population was 43%, which actually was superior to the overall response rate in the paclitaxel-pembrolizumab combination, indicating that capecitabine may well be an appropriate chemotherapy partner for immune therapy. We've also seen the results from the ENHANCE-1 study. This is a study looking at eribulin together with pembrolizumab in patients with advanced metastatic triple-negative breast cancer with 2 phases of this study. And we saw initial data a couple years ago and then more recently updated at this past ASCO by Dr. Sarah Tolaney, demonstrating that PD-L1 positive were more likely to derive benefit from the combination than those who had PD-L1 negative tumors, and that those who were earlier on in their course of treatment also derived more benefit from the combination. AKT inhibitors have been shown together with taxanes to improve overall survival in 2 phase 2 studies, the PAC study and the LOTUS study. And there's reason to believe that AKT inhibitors might synergize together with immune therapy. So there are a number of studies underway looking at combinations of taxane with AKT inhibition and immune therapy. So this is one of the early phase studies. The AKTI study, this is a phase 1 study of ipatasertib, atezolizumab, and paclitaxel or nab-paclitaxel, with a safety run-in and expansion phase, and they demonstrated in this small but impressive study an incredible waterfall plot with a number of responses with this combination. So a number of global phase 3 studies are underway looking at various combinations of AKT inhibitors with a taxane and immune therapy. What about other drugs? Are there rational combinations for other biologic agents, say PARP inhibitors, for example? And the Tapasio study looked at this question. It explored the combination of niraparib together with pembrolizumab in metastatic triple-negative breast cancer patients who had received less than or equal to 2 prior lines of chemotherapy for their advanced disease, and saw an overall response rate in 28% of patients. And notably, only 22% of these patients had a deleterious germline BRCA mutation, indicating that this might be a combination that's relevant for a patient who have a wild-type BRCA status. Here's the Mediola study. This is a study focusing on the germline BRCA mutated status specifically for those with HER2-negative metastatic breast cancer. This is a study with a olaparib run-in, so a run-in with a PARP inhibitor, followed by PARP inhibition with olaparib together with durvalumab. And they've reported impressive swimmer plot data, as you can see here, with disease control rate at 12 weeks of 80%. And in other more recent updates of the study, duration of response by prior lines of chemo, so not unexpectedly, those who have less heavily treated disease derive more benefit and have better progression-free survival. So there are a lot of other strategies. PARP inhibitors have been implicated as effective maintenance therapy after treatment with taxane platinum combinations. And I just want to highlight an ongoing global study, the DORA study, looking at patients who have advanced metastatic disease, who have stable disease or a response after platinum-based chemotherapy. And then those patients are randomized to receive olaparib alone or olaparib together with durvalumab as maintenance therapy. There's also some data from other tumors. This is data from renal cell carcinoma looking at VEGF-directed therapies. So as you can see here, and looking at atezolizumab together with the VEGF-targeted drug bevacizumab together with sunitinib, there was an impressive hazard ratio of 0.64 when compared with atezolizumab versus sunitinib without the bevacizumab, without the anti-VEGF directed therapy. So head-to-head comparisons are discouraged. However, it does indicate that there is a role for VEGF directed therapy in specific anti-cancer combinations, and these combinations are being explored again in breast cancer. So are there opportunities to optimize treatment for patients with triple-negative breast cancer? So historically, we have layered on additional medications that appear promising. Are there opportunities to actually de-escalate or optimize chemotherapy backbones by adding in more biologically rational, effective therapies? And so the question arises, could rational immune therapy strategies allow for de-escalation of chemotherapy backbones? And radiation represents one such strategy. Radiation does a few different things. It actually draws immune cells into the area, so it's immunogenic itself, but it also physically disrupts tumors and therefore may be particularly effective at presenting neoantigens for immune therapies to respond to. And there is a huge body of preclinical data indicating that radiation together with immune therapy is effective and is effective for breast cancer cell lines specifically. And thus my colleagues and I have undertaken studies exploring immune therapy with radiation in the palliative setting. This is a study where we explored pembrolizumab together with radiation in patients who required palliative radiation. And here you can see a patient who has widely metastatic breast cancer and an intact primary. The intact primary was going to break through the skin, and so she was referred for palliative radiation. She received radiation to that breast mass and also received concurrent pembrolizumab and had a dramatic, durable response. And in fact, One of the patients who we treated on this study who had a lung mass that was irradiated actually had a durable response of over 2 years duration and did not require systemic therapy to maintain her NED status. So we have had a tremendous amount of excitement for these strategies and have since taken them into the curative intent setting. We have recently reported preliminary results from a preoperative study combining radiation with pembrolizumab prior to standard of care neoadjuvant therapy for patients with triple-negative breast cancer specifically, and have reported a pathologic complete response rate of approximately 71%. And thus, this is deemed promising given that chemotherapy alone typically confers pathologic complete response rates of 40 to 50%. And thus, we are taking this strategy into a larger phase 2 randomized study. Are there other strategies that can be employed to draw immune cells into the tumor environment, but also optimize antigen presentation through physical disruption? So this is work done by James Allison's group. He, of course, won the Nobel Prize a couple of years ago for his contribution in developing key checkpoint blockades and the subsequent successful development of drugs that target those checkpoint blockades. And Becky Waits in his lab did this work demonstrating that if you froze a tumor through what we call cryoablation and co-administer immune therapy, not only does the tumor not grow, but it also prevents re-challenge, indicating that you've successfully trained the immune system to recognize tumor-specific information, such that if you present that same animal with the same information, tumor implantation is not successful. So we were very excited about this data. And when I was at Memorial Sloan Kettering, my colleagues and I undertook a curative intent study where we worked backwards from patient surgery date to administer cryoablation together with checkpoint blockade. Here you can see the tumor probe in the tumor. You can see the generation of an ice ball. And then you can see in the tumor cavity tiny fragments of tumor generated by the cryoablation procedure. And we were able to show that not only were we able to create a robust immune response within the tumor itself, but we also created a robust systemic immune response, indicating to us that these strategies were successfully training the immune cells to recognize and remember cancer-specific information. And we presented the update of this study last year at ASCO and demonstrated that with more than 5 years of follow-up, we had had no recurrences, including in our triple-negative population. And we have since undertaken a study of cryoablation with combination immune therapy that has directly informed a currently open study of cryoablation versus immune therapy in patients who have residual disease after standard of care neoadjuvant therapy. So here's my takeaway of where we are and where we're going. The impact of immune therapy has certainly become a new pillar in the treatment of triple-negative breast cancer, as established by the recent FDA approval of atezolizumab together with nab-paclitaxel for the treatment of locally advanced or metastatic triple-negative breast cancer. And certainly we anticipate additional FDA approvals in the curative intent setting, given the data that we've seen from Keynote 522 and the data that's promised from Impassion 031. However, there are several key clinical challenges that remain and unanswered questions. Specifically, how do we pick patients more effectively? What are the most rational combination strategies? Do we need to focus on the patient tumor or tumor microenvironment specifics to predict who is most likely to respond to what types of therapies? So certainly there are a lot of questions that we still need to answer if we're going to make these strategies appropriate for the majority of our patients. And certainly collaboration is at the heart of this future. Doing small studies in individual institutions will not lead to meaningful, efficient answers in this space. And I just wanted to point out that there are many different organizations that are supporting research and collaboration amongst industry, academia, and other key stakeholders Several of them are listed here: the Breast Cancer Research Foundation, Susan G. Komen, TBCRC, Parker Institute, Stand Up to Cancer, Alliance Foundation Trial, SWOG, and so many more. And these partnerships across academia, industry, and key stakeholders is the only way that we can move the field forward in a meaningful way. An example listed here is the Tribute study that is supported by Parker. And this study is looking at biomarkers that will predict for responses to nab-paclitaxel with atezolizumab in the metastatic triple-negative breast cancer setting. There's certainly a number of other studies underway looking at vaccine strategies, looking at strategies that harness immune therapy for the treatment of other tumor types, including hormone receptor breast cancer and HER2-positive breast cancer. So certainly we have a lot of work to do together to move this field forward. But I am very excited about the promise of immune therapy and our ability to improve cure rates and more effectively treat patients with metastatic disease. And it is my hope that this is the future cover of Science magazine, that we have cured cancer with the effective administration of immune therapy. I want to thank you for joining me today. I hope that you found this material interesting and useful in your clinical practice.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/KFY860. This activity is supported through educational grants from Bristol Myers Squibb, Eisai Incorporated, and Genentech. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.